Our next presenter is Dr. B.S. Yadav from the Indira Gandhi Medical College, presenting GS512, hypofractionated radiotherapy in patients with breast cancer, acute toxicity data of a phase 3 randomized study.
Can I have my slide? Good morning from India. I thank the organizer for giving me opportunity to present my abstract. So I will be talking about hypofractionated radiotherapy in patients with breast cancer, acute toxicity data of a phase 3 randomized study from Chandigarh, India. Next slide, please. The study design was, hypofractionated radiotherapy in breast cancer is a phase 3 randomized open-label multi-centric study of adjuvant radiotherapy in patients with breast cancer. In this study, we compared 3 weeks of adjuvant radiotherapy schedule with 2 weeks schedule. The trial was approved by Institutional Ethics Committee, and this was also registered with clinicaltrial.gov. Next, please. Now, coming to material method, the inclusion criteria for the trial were patients with invasive breast cancer, age 18 to 80 years, who had breast conservation surgery or mastectomy with axillary staging, with complete microscopic excision of the primary tumor, pathological T1 to T4, and pathologically N0 to N3 and M0 disease, and who were able to give written informed consent and were able to comply with the follow-up. Next slide. So from June 2015 to December 2020, patients with breast cancer who needed adjuvant local-region radiotherapy were randomized to the study arm, who were given 34 gray in 10 fractions over 2 weeks, and the control arm were given 35 gray in 15 fractions over 3 weeks to the chest wall, and 40 gray in 15 fractions to the breast. Boost when indicated, it was given 8 gray in 2 fractions in both the arms. Patients were planned on 2D simulator with 2 tangential fields to the breast or chest wall and incident supraclavicular fossa field. Supraclavicular fossa was radiated in patient who had node positive disease or who had T3 disease, and internal membrane nodal irradiation was done in patients who had central or inner quadrant T3 lesions or N2 disease in the axilla, or if there was PET positive disease pre-chemotherapy or pre-surgery. Next slide. The outcome measures were, primary outcome measure was local recurrence at 5 and 10 years. I am going to present here the secondary outcome measure, that is acute toxicity, which was assessed with RTOG grading scale weekly during radiotherapy and 4 weeks after treatment completion by the physician. And cosmetic outcome was assessed by using Harvard and SABP RTOG scale at 1 and 3 years. The toxicity between the two arms was compared using Fisher's exact test. Next slide, please. So overall, we assessed 1139 patients for the eligibility, and 18 patients were excluded. 9 didn't meet the inclusion criteria, and 5 patients refused to participate in the trial, and 4 patients had other reasons. So total 1121 patients were randomized in 2 arms, 557 in the 3-week arm and 543 patients in the 2-week arm. And these patients were followed up and these are analyzed. Next slide. Now coming to the results, as we can see in this table, the patient characteristics are well matched in both the arms, except for there were more mastectomy in the 3-week arm as compared to 2-week arm, and it was statistically significantly different. Next slide. This table shows pathological characteristics of the 2 arms. They are well matched, except for the nodal positivity rate. It was more in patients with the 2-week arm, and there were more estrogen receptor positive patients in the 3-week arm, and this was also significant. Other pathological parameters, they were well balanced between the two arms. Next slide. So the systemic treatment, chemotherapy and trastuzumab was well balanced between the two arms, but hormonal therapy was more in 3-week arm because of more estrogen positive tumors. And this figures on the right side shows the radiotherapy planning on 2D simulator with the central lung distance was kept around 1 to 2.5 centimeter, and supraclavian fossa was treated by a single incident field. And for intermammary node irradiation, we included upper 3 intercostal spaces, and those were prescribed at 3 centimeter. And dose for the intermammary node irradiation was similar in each arm. That was 34 gray 10 fraction over 2 weeks, or 40 gray in 15 fraction over 3 weeks. Next slide, please. This table shows the radiotherapy detail. It is well balanced between the two arms. Most of the patients, around 85% in each arm, received radiotherapy to the breast, chest wall, and supraclavian fossa. Breast and only chest wall was given to around 15% of the patient in both arms. Internal membrane node irradiation was done in 40%, more than 40% of the patients received radiation to the internal membrane node. And boost was given in around 16% patient in the 3-week arm and 17% patient in the 2-week arm. Majority of the patients were treated only neck, and bolus was used on alternate days in patients who underwent mastectomy. Next slide. Now coming to the acute toxicity, most of the toxicity was grade 1. It was 38% in the 3-week arm and 35% in 2-week arm. Grade 2 toxicity was 17% in 3-week arm and 15% in the 2-week arm. And grade 3 toxicity was only 3% in 3-week arm and 2% in the 2-week arm. And it was comparable between the two arms. Next slide. Median follow-up was 35 months. So we assessed the cosmesis, which was assessed at last follow-up in this patient, and it was seen that excellent to good cosmesis was seen in 90% of the patient in the 3-week arm and 94% of the patient in 2-week arm. So it was statistically significantly different between the two arms. It was better in the 2-week arm. Next slide. So to conclude, the two radiation schedules were compared in terms of acute toxicity, and cosmetic outcome was better in 2-week arm. Next slide. Thank you. I would like to acknowledge the funding support provided by Science and Engineering Research Board from India, and we also thank all the participants and the supporting staff, and special thanks to Gary Clark for providing his statistical backup for the trial. Thank you.
Thank you, Dr. Yadav. The floor is now open to questions, either at the microphones or virtually. Do you see someone? Number 3, please.
Yeah, I'm Dr. Manish from India. Congratulations for this nice presentation. The trend is towards 5 days of radiation rather than 1 week of radiation versus 2 weeks of radiation. Would you be doing any further studies of 1 week radiation?
We are already doing 1 week radiation trial, that is HIPAR trial, and it is also registered in the clinical trial .gov, and it has been started since January 2022. So around more than 300 patients has been enrolled in that trial.
Microphone 2, please.
John Benson from Cambridge. So yes, my question follows on a little bit from that. So I mean, you're familiar with the Fast Forward trial with 5 fractions, and you've just alluded to future studies that you're doing. So how does that differ from the Fast Forward trial, which was 5 fractions, about 5.2 gray per fraction?
So my future trial is I'm comparing 2 weeks, 34 grain 10 fraction, the same schedule which I presented here, with 26 grain 5 fractions. So, and in this trial, we are using all sorts of techniques, 2D, 3D, DIBH, SIB, whatever is feasible in all the patients.
Okay, microphone 3, Dr. Olapade.
Yeah, thank you. Really very nice talk. And I just want to ask whether you're grading skin toxicity based on the shade of the color of the skin. Because as you know, the darker the shade, the differences in terms of skin toxicity. And I just want to know what grading system you're using and whether the comparative group is a white skin or a darker skin. Because I think those are really important questions for early toxicity grading.
So like we have brown colored patients. So both groups, they are same color. And I think this acute toxicity doesn't really depend on the skin color. And the grading system which we use is RTOG grading system. So it is like grade 1 is erythema, grade 2 is dry discoloration of the skin, and grade 3 is if there is moist discoloration.
Yeah. And to follow up on that, the question really has to do whether there's also a difference between the right side, the left side, and sort of the granular data that we need also in terms of subtype of breast cancer, because the short-term toxicity versus long-term would be things that clinicians want to know. Obviously, it would be cheaper to do a two-week fractionation.
So, like, it doesn't really depend on the site of the breast, whether it is right or left, but it depends on other parameters like general physique of the patient. It tends to be more in patients who are obese and patients who have more folds in the breast or axilla. If the patient is diabetic, she tend to have more reaction. If there is poor wound healing, those kind of patients, they also tend to have higher reactions. And if you tend to use more bolus in more number of actions, that can also increase your acute toxicity rates. And sometimes if you're using trastuzumab concurrently, so these patients, they have diffuse grade 2 or grade 3 reactions sometimes.
Thank you, Dr. Yadav. Looks like we have no more questions. Oh, number 3, one last question. We have 48 seconds.
There was a very interesting observation and a paper which was presented in the ASCO meeting 2022, where skin decolonization was done, and they could reduce the side effects of the skin toxicity. This was in ASCO. Does it make sense to use it in shorter trials where skin toxicity may be slightly higher, and you can actually do bacterial decolonization and protect these patients from skin toxicity? Just a thought.
So like if there is a poor wound healing or there is infection in the bone, so those patients, they tend to have higher skin reactions, and it is for sure. So that may work if you can decolonize the skin. If it is clean, it is healthy, the chance of reaction will be less in the skin.
Thank you very much. I would like to thank the in-person as well as virtual audience for their participation. I think this concludes our session. Thank you again.
Thank you.